And great. We'll get started. Again, this is Karen Scott. I'm president of the Foundation for Opioid Response Efforts, and I will be moderating today's webinar. Ken, can we have the next slide? Oh, thank you. Our agenda for today, we'll do a little bit of going over logistics, and I will just introduce the foundation for those of you who are new to participating in our webinars, and then we'll be turning to today's topic, which will focus on all of the very rapidly occurring and changing federal and state actions that will impact access to medications for opioid use disorder and other services for patients with opioid use disorder and their providers and health systems that they're relying on. I will be introducing our panelists shortly. We will be joined by Jocelyn Guyer from Manatt Health Strategies, Jodi Manz from the National Academy for State Health Policy, and Dr. Hannah Schneider, a physician with the California Bridge Program and at UCSF Medical Center. Next. So just a few reminders. We will be recording this webinar, and we'll make it available shortly on our website. We will also provide the PowerPoint presentation, and that will be available for you to download on our website as well. The Q&A part of the webinar is very important to us, and we encourage your questions and your engagement. And when we get to that part of the webinar, please use the Q&A bottom found at the bottom of your Zoom screen. We will collect all of the questions there, but that also allows you to upvote on questions that may already be in the queue if there's a question that's similar to the one you had, so that we make sure we try to get to those. We will read as many questions as we can during the webinar. In addition, we will collect all of the questions and work on an FAQ document to go along with the webinar material, and post that on our website as soon as possible. If there are any resources that you would like to share with everyone, please send those to us at info@forefdn.org. We are happy to review them and continue to expand our capacity to share resources and make those available more widely. Finally, there will be a brief survey immediately following the webinar. We would love your feedback. We are planning to continue to provide the webinars as a resource, and I want to make them, again, as useful as possible to all of you on the front lines of this work in so many ways. And for those of you who are new to participating in our webinars or in other work with FORE, just a little bit about the foundation. We are quite new. We were founded in 2018 as a private national grant-making foundation with a focus solely on supporting solutions to the opioid crisis. We set as our mission to convene and support partners advancing patient-centered, innovative, evidence-based solutions to impact people with opioid use disorder, their families, and their communities. And we're committed to funding a diversity of projects that contribute solutions to the opioid crisis at a national, state, and community level. Many of you may have seen our first request for proposals, which was launched last summer, and that RFP focused on looking for projects to expand access to treatment for very vulnerable populations. We were thrilled with the incredible response across the nation to the RFP, and very excited to announce the grant awards coming out of that RFP, which we did just earlier this month. Feels like a long time ago. 19 grant awards make up our first cohort of grantees, and information about those grants, again, can also be found on our website. As we move forward, our overall approach to our grant making will be to take a very comprehensive approach. So we'll be looking for where the opportunities for the foundation may be related to, as they relate to provider education, payer strategies, policy initiatives, and public awareness. So that's our long-term program planning guide. And while we continue to work on developing that long-term plan, obviously the world has really changed around all of us in the last few weeks. Then next slide. And we wanted to also look for some ways to provide some broad assistance during this time of great uncertainty and incredible change. And we really saw our opportunity was to help in making the connection between the impact of the measures that we need to take in response to COVID-19 and the impact of those measures on people with opioid use disorder, and the providers, systems, and communities on which they rely. So to that end, we have been reviewing and posting resources on our website, all labeled as COVID-19 resources, and hope that this is a place where people will increasingly view as a site with trusted information and we will continue to build that out. Last week, we ran a national webinar with Dr. Hannah Schneider and over 500 participants on beginning to think about what the impact of the measures we take for the pandemic will mean for patients with opioid use disorder. Given the response that we had to that first webinar, we're now planning to do the webinars as a weekly series over the next several weeks. And this will really allow us to delve into many of the topics that were raised during the webinar, the questions that we received during and after the webinar last week. We will also continue to look for ways to facilitate connections with experts and technical assistance, and again, would love to hear your ideas and guidance so that we can make these activities as useful as possible to the work that's very immediate and challenging to all of us in the field right now. Great, and we can go to the next slide. Sorry, for our panel today, we are thrilled to welcome Jocelyn Guyer, who's a managing director at Manatt Health Strategies, and Jodi Manz, project director for chronic and vulnerable populations at the National Academy for State Health Policy. In last week's discussion, we heard very much the need for continued and further detail on the federal and state policy changes that are occurring and at very rapid speed, and how these will impact both patients and providers in the addiction medicine and in the treatment of opioid use disorder in the immediate term. Both Jocelyn and Jodi have been working furiously and doing amazing work to keep up with both changes at the federal agency level, as well as the whole range of changes occurring across different states react and respond to federal guidance, as well as to their local population. So we are thrilled to have them as partners and to turn over this discussion to Jocelyn right now to get us started. Thank you, Jocelyn.
Karen, and we very much appreciate the Great, thanks very much, Karen, and we very much appreciate the opportunity to participate in this series, which is incredibly timely, and we particularly appreciate the chance that you've framed this as we're all working in this together as a community to figure out responses in a dramatically evolving landscape, and so happy to be a part of that. Why don't we go to the next slide? So before we jump in, to start with I think that the refrain that we all need to use these days, which is as we talk through state opportunities and options to assist people with opioid use disorder through the epidemic, we're all highly cognizant it's a rapidly changing policy and regulatory environment. And part of, Karen mentioned that we've all been working furiously, of course, since last night when the Senate passed a bill that actually has some provisions directly relevant to our conversation today around how to support people through this pandemic. We are not going to cover them in depth today, but just at a very high level, we're going to be seeing vast new resources going directly to states, $150 billion. $100 billion to support providers. I think key questions around where do opioid use disorder providers fit in that mix. Some telehealth changes, which we will touch on today because they're very, very relevant to the practical focus of today's calls around state options to support telehealth and other immediate strategies. And then some privacy and security changes, which also are directly relevant. So we're going to start to weave those in, and then I'm sure this is an ongoing conversation. I think it's also important to note that even with all of us working together to untangle what's allowed, what's encouraged, some of the answers are going to remain unclear. And so this is a time when I think for those of you sitting in state agencies or local governments, there's going to be a question of kind of risk tolerance, you know, in the absence of clear answers. How far do you feel comfortable going? And we'll be here to try to sort through kind of the implications of that. I would just share, Manatt works directly with a number of states, and we are seeing a very responsive approach from the federal government in terms of telling states, go ahead, do what you need to do. We will clean up the paperwork later. I think reflecting the severity of the epidemic. And then the last caveat I want to say is we're going to be walking through state options and sources of flexibility. It's important to note that some of those are going to be temporary and directly linked to the public health emergency. And some of them are actually long-standing options that are part of federal law. And so an interesting conversation to have someday in a few months, maybe which of these changes do we want to adopt on a permanent basis to help people with opioid use disorders, and which of them really, you know, we're going to go back post-pandemic. So we'll try to flag for you as we go through what's permanent state options and what's linked to the pandemic. Let's go to the next slide. So just to say in terms of why we're focusing on this, and I think it was really well covered in last week's webinar, we know that people with opioid use disorder, a particular challenge that you face when you're using opioids, whatever the form, is it has a big impact on your breathing and your respiratory function, and so does COVID-19. So we've got a population at very high risk in the current pandemic. We also know that people with opioid use disorder are more likely to experience homelessness and incarceration. And so all of the risk factors related to COVID-19 that go with that will be arising for them. I'm sure we've all seen the news about, you know, we've already got cases in Rikers in New York City's jail. So a scary situation, highlighting the importance of these conversations on how to help this population in particular through the pandemic. And then we know that during this pandemic, everyone is supposed to be home, alone, and that's a very high risk situation for people who are using opioids at risk of overdose if they don't have a friend there or someone that they're with who can flag that. So that's why we're so grateful to FORE and others for really focusing in on this population, even though there's a lot of things going on right now. Let's go to the next slide. So one of the things, so for those of you that didn't have a chance, I had a chance to listen to last week's webinar where Dr. Hannah Schneider presented, and I would recommend a lot of things in this current pandemic are kind of flash in the pan. You know, it was good for Monday, but not for Tuesday. But I would highly recommend going back and listening if you can, because it's a, you know, comprehensive, incredibly thoughtful overview of what we need to do in terms of how to approach clinical care for people with opioid use disorder during this pandemic. And our focus today is state policy options, but a quick refresh, and Hannah, you can jump in and correct me if we mangled any of your beautiful framing from last week, which I really do encourage people to listen to directly. But just in terms of what are the state policy options, but what is it we're trying to support? And I think what we're trying to support is maximum use of telemedicine to allow treatment to continue even as people are isolating at home, not going to the doctor, not going to peer groups, those kinds of things. As much flexibility as possible to get buprenorphine and methadone into the hands of people who need it, even when they're not able to come into, for an example, an OTP. Recognizing and dealing with the reality that peer supports are a key part of the equation for folks, and we've got to come up with some strategies for helping them and during this time of social isolation to continue with that peer support, keeping a sharp focus on harm reduction efforts, supporting the frontline providers in the OTP clinics, in the hospitals who are trying to work with people with opioid use disorder and feeling their own tremendous anxiety and stress around what the pandemic means for them. And then the last thing, and you'll hear this, Jodi from NASHP is going to talk a lot about this too. There is so much confusion that, again, especially for those of you that are in the position to work with your state on its policies, incredible need for clarity to opioid use disorder providers and patients as to what they can and should be doing. So we're going to be thinking about kind of this framework through the lens of policy options as we go forward today. And I will just say, you can leave it here, Ken, but just to say, we're actually not going to cover everything that Dr. Snyder outlined last week. We're going to focus in on the first two, the telemedicine and the buprenorphine and methadone, and a little bit on counseling, mostly because this is going to be a marathon and not a sprint as we go through this together. Okay, so let's go to slide 12. So again, as background context, I think as we started to go through and try to lift up where the state options are, you immediately kind of run into medication opioid use disorder treatment is an incredibly heavily regulated space, right? So even more probably than anyone else in this pandemic, we are looking and trying to pull together regulations, guidance across multiple federal agencies to get to the state options. So we've got SAMHSA, which oversees certification of OTP programs and also oversees Part 2, the rules around sharing information. So they've got, of course, a huge role to play here. We've got the Drug Enforcement Administration, which has a hand because the medications we're using are controlled substances. You know, I think they've actually been doing an admirable job kind of coming along with us, but they have other things on their mind. I think folks might have seen they just put out a $15 million order to try to find the president of Nicaragua. So like they got lots of stuff going on, but hanging in with us. Within the Department of Health and Human Services, we've got CMS, which is overseeing Medicare and Medicaid policy. Incredibly important because so many of us need to know what are the circumstances under which we can still get paid through Medicare and Medicaid. So huge role there. And then there's other agencies within HHS, including the Office of Civil Rights, which oversees enforcement of things like HIPAA, which, you know, part of what we need is some more flexibility around sharing information during this pandemic. So these are some of the players that we'll be talking through where policies are. And of course there are more, but these are some of the major ones. Let's go to the next slide. So I think what we really want to focus on though today is kind of where states can step in. And so a little bit on kind of the tools and the levers that states have as they go through this pandemic. And they come from, it's that dance, right, between the feds and the states. So the feds have put forth these levers for state flexibility. And the first one is the 1135 waivers, which frankly have mostly been oriented around, we've got overwhelmed hospitals. Some of them need to set up different sites. You know, we need to have flexibility around the conditions under which providers are participating in Medicare and Medicaid and the Children's Health Insurance Program. One piece of that I think I want to lift up for this community in particular is that these 1135 waivers are the source. If you need some quick hit flexibility as a state to say, you know what, this is not the time for a lot of prior authorization requirements, including on the medications we use for OUD, you know, we are temporarily suspending them. That is through the 1135 waiver authority. So potentially quite important for some aspects of our work. The 1115 waivers are much broader, traditionally huge, complex waivers, but we are seeing the current administration tell states, if you need some quick hit help with waiving Medicaid provisions that you can't get to with 1135, let's look together at 1115 waivers. The thing I think, this is probably a couple weeks or months down the line, it's not for today, but these may be a very important vehicle for supporting opioid use disorder providers, even as they, you know, potentially see shrinkage in the number of clients they're able to serve. The key thing about these waivers is they open up Medicaid dollars for uses that are not otherwise allowed. So we'll probably want to come back on those. Appendix K, for those of you that are in the nitty-gritty on this, is a source of flexibility for changing how you serve your home and community-based waiver populations. So folks that need, intensive treatment at home to get through this pandemic, some important new flexibility there. And then we've got the federal legislation, and we already talked a little bit about, we're gonna have to come back on the $150 billion going to states and other things that I think it's going to be really important to make sure that the folks affected by opioid use disorder are part of that thinking and that calculus at the state and local level. In terms of the state flexibilities, obviously lots at your state level. A lot of it starts with the emergency declaration. I think when we started these slides, there was a state or two that was not yet in the emergency declaration, but everybody's there now. And it's important just because it turns on and interacts with sources of flexibility, like to pursue an 1135 waiver, to have an emergency declaration. And then the last thing to focus on is, because we've all been pretty focused on like, oh, we need a waiver to get through this. Actually, some of the policy changes that we'll be talking about in options are rooted in just longstanding federal law. And so we've kind of been dusting off some of those sources of flexibility. So sometimes what you might need is a good old fashioned Medicaid state plan amendment to go ahead and clean up and do what you need to do to get folks with opioid use disorder through this pandemic. Let's go to the next slide. So kind of, and Jodi may want to jump in on this too. I think one of our themes and messages for you is we're going to turn next to the concrete specific strategies, but hopefully one of the things this backdrop has done is just highlight the overlapping and complexity of this situation, which I probably didn't need to highlight because many of you probably live it. But I think just to say, in this environment and for opioid use disorder in particular, it's going to be critical for those of you in state positions to put out clear guidance around what the expectations are for your providers, and for your providers in turn to share that with the people that they're serving. Even if, and sometimes it can just be like a reiterating of what SAMHSA has said, in part because, as we're going to talk through, sometimes the things that SAMHSA allows do not automatically flow down to the state level unless states step in and take advantage of it. And so in this environment where everything is multi-layered, it's going to be essential to have that clear guidance. And there are different topics that it can address, and we're going to talk through some of the specific items, but certainly, clinical protocols and ideas for how to handle the COVID-19 response, guidance to your behavioral health providers on the extent to which they're considered essential, and you really are hoping, anticipating, expecting that they will remain open, places where you're going to take the foot off the gas when it comes to enforcement on a temporary basis during the emergency, all sorts of things. And I think one of the most useful things that FORE is doing is helping to put together resources and examples. And so I do think this is a time, and we always do it in state work, to beg, borrow, and steal from each other in terms of getting some good, clear guidance out. And so we've just lifted up a few states, and there's many more who are starting to get some really good, strong, clear guidance out. So we've got Connecticut that is really looking at helping their providers, their behavioral health providers in particular, think about leveraging telehealth. So that's a good place to look for some sample language. Maryland has jumped in on some strong guidance for recovery homes. Many of you probably are already running into folks who need opioid use disorder treatment in an institutional or residential complex when they're trying to get out and transition out. Sometimes we're seeing recovery homes shut down and not take them. So some good guidance for Maryland to provide some reassurance there. And then Ohio is a place, and people may have seen this because SAMHSA also has lifted Ohio up. They've released a very comprehensive COVID-19 guidance, including some ideas on funding opportunities to help opioid use disorder providers figure out telehealth and make that transition, how to get naloxone out, and how to help OTP facilities reach and continue services for their patients who have COVID-19. So we're hoping you will take a good look at those. Why don't we go to the next section? Okay, So what we wanted to do in the rest of this, and Jodi and I are going to kind of tag team on it, and we're hoping that you all will be sending questions as we go, and flagging, you know, that's not how it's unfolding in my state, so we can kind of work together to untangle what's going on. But if we go to the next slide, we're going to start with where we are in the telehealth. And I know Dr. Snyder talked about this last time, and we thought it would be important to do kind of a refresh and then also layer in some of the changes we've seen in the last week. Before we jump in, though, I think it's important just to kind of try to break down telehealth and what you need in place for it to really work for this population. So we need providers who are allowed to do telehealth, and we'll talk a little bit about some states that are really pushing the envelope to make sure that their licensed addiction counselors are part of the providers who can do telehealth. So from the perspective of OUD, there's lots of talk about, you know, of course, doctors can do it, nurses can do it. We want to make sure we're reaching into, at least for Medicaid payment purposes, the broader array of people who work with opioid use disorder folks. We're going to need technology, right? How are you going to do it? Is it through Skype? Is it through a licensed telehealth provider that you've had for 2 years, or are you kind of doing this on the fly? So we'll review where we are in that. We are seeing some states looking at more financial support to help practices make this transformation. I also think there's a huge amount of money in the new bill to do this. So that's a key piece of things. Some reassurance that you're not going to run afoul of privacy and security requirements and kind of get dinged on it. So we can review where we are on the HIPAA and the Part 2. And then, of course, people have to get paid because part of this is making sure we can get the infrastructure of providers who serve those with OUD through this pandemic so that when we get to the other side, they will still be there and serving people, as well as, of course, helping people as much as possible during the current pandemic. All of what I just said is relevant for everyone who tries to do telehealth, and that's everyone these days. And then there are some very specific, because we're dealing with controlled substances, telehealth issues that intersect with the reality that sometimes we're trying to get people controlled substances. So we'll talk through that as well. Let's go to the next slide. I'm actually somewhat counterintuitively going to start with Medicare, even though we recognize that many of you, to the extent you're working with insured patients, it may more likely be Medicaid. And the reason is because what we're finding is for a lot of states, kind of the Medicare and the Medicaid clarifications and guidance coming out of the federal government are kind of they're all feeling tangled together. So we thought we would just start with a quick recap on where we are with Medicare, and then where we are in Medicaid, which is frankly far more wide open. So we'll talk through that. So first in Medicare, you know, lightning speed, we've probably done 10 years of, you know, kind of unraveled 10 years of regulation on telehealth in 2 weeks. And so Medicare now is suddenly, because of this pandemic, in a place that is very flexible, where there's a huge push towards telehealth. Now that, you know, we can have, you know, providers can be, regardless of, they're allowed to start telehealth, regardless as eligible originating sites. A lot of that used to be restricted to people living in rural areas. That's gone. So whether you're in New York City or West Virginia, you can do telehealth with a Medicare provider and they will still get paid for it. No longer need to have an established relationship with a patient. It used to be like, if I already know you, I could do telehealth with you maybe in some circumstances. Now you can initiate it. We can do telehealth across line in Medicare. So really wide open at this point. We also did see in last night's bill, which we do think is going to pass, many of us were kind of stuck on this, our community health centers, which are such an important provider for people with opioid use disorder in many places. They were not able to serve as originating sites for telehealth under Medicare payment policies, and it was really kind of getting stuck. But the congressional bill that should pass tomorrow is going to clean that up, at least for the duration of the pandemic. Let's go to the next slide, and then just say, and we can go to the next slide, but as we're transitioning, just to say that Medicaid is wide open on those kinds of things. From the privacy and security perspective, we have seen both the Office of Civil Rights come out and say that they're not going to impose penalties on providers if they're doing telehealth, even if it's using a platform that's not HIPAA compliant. So you can do Facebook Messenger, FaceTime. There's a few things they really don't want to see you do, like live streaming a interaction with a patient or TikTok. So, some reasonable restrictions there. And then under SAMHSA policy, because remember we said SAMHSA has a big role in Part 2, they are going ahead and using existing flexibility that has long been in the Part 2 rule to say that you can go ahead and serve an opioid use disorder patient even if you don't have the traditional consent requirements, if you consider it a medical emergency. And I think most people would consider our current situation an emergency. Let's go to the next slide. Okay, so let's go a little bit into we are dealing with controlled substances. We do have the Drug Enforcement Agency came forward and said our Schedule 2 through 5 controlled substances can now be prescribed via telehealth visits, even without an initial in-person evaluation. They are still looking for an audio-visual interaction. They're not really wanting to see telephone only. And so it's not everything we're looking for, but it's a good, strong step forward. A little bit of that's what DEA says. SAMHSA, however, is opening up the doors a fair amount, but not quite as far as that. They are saying that new and existing OTP patients can be treated with buprenorphine via telehealth throughout this public health emergency. However, they are still, for purposes of methadone patients, wanting to see those folks have an in-person medical evaluation first. So I think at the end of the day, we've kind of got a little bit of conflicting. DEA is actually a little wider open, but I think for now, the SAMHSA rule that you need to have an in-person medical evaluation is going to be determinative. Let's go to the next slide. Okay, so let's give you a little bit more specific examples on this. So, and many of you have probably been involved with these policy changes, and this is with respect to Medicaid. And the kind of takeaway on Medicaid relative to Medicare is you all, at the state level, control the Medicaid policy on when Medicaid will pay for telehealth within some of those parameters we just described. So we have seen 36 states amend their telehealth policies in Medicaid in the last week or two. We're seeing huge strides forward, and we encourage you all, if you haven't done this already, to take a look at these options. Mandating coverage of telehealth across an array of providers, allowing for the same payment levels, whether a visit is telehealth or in person, allow visits to be conducted at home. So if you've got a provider at home, they can be, that's an eligible originating site. Allowing, and this is where, it's like sometimes like Medicare doesn't let you do that, but Medicaid does. You can do telehealth just on the phone, which for some folks with OUD, they may not have Skype and a laptop, but they might have a phone. And so states can and have said we will pay for that in the Medicaid context for now. Just, sort of the warning, sometimes the Medicaid policy is there and in the right place, but you have to look at state licensing requirements and make sure they support it. But states generally are doing, I think, a pretty good job of coordinating across those two areas. I'm going to pause there and have Jodi jump in with some specifics on what we're seeing in states.
Yeah, thank you so much, Jocelyn, and all of you for listening, and of course all the folks at Manatt and FORE for helping us put this together and really trying to keep tabs on what's happening across states. The federal agencies, as we just saw, have very quickly put out significant guidance around a lot of these topics, but states are implementing those things differently. And are communicating those things differently. Sometimes you'll see that information come from licensing boards, from secretaries or governors, oftentimes through Medicaid memos, and that's one of the pieces we're going to focus on here. So just to draw out a few examples, and these are certainly not exhaustive, but just a few. North Carolina has issued pretty significant Medicaid guidance around telehealth, establishing parity for payment for telehealth services. And we've seen this in a few states where rates have been raised in order that those telehealth services are reimbursed at the same rate that they would be were these services provided in traditional ways. Expanding those eligible originating sites similar to what Medicare is doing. And then making new technologies available, as you saw, the feds kind of open that up and states are allowing that. North Carolina also expanded the types of providers that can provide telehealth services, and this is a big one, and one that we've seen as a theme across states as well, where folks who previously didn't have the reimbursement mechanisms or the methods to provide telehealth services are now able to do that. And then eliminating the need for prior authorizations and referrals. Some states have already waived prior auth for various pieces of prescribing in telehealth, others had not. So this has been an opportunity for states to go ahead and do that in an emergency setting. Washington has been doing a lot of really interesting things with their telehealth provision. And they were one of the earliest states to submit an 1135. And one of the things that does is it suspends behavioral health licensing and certification requirements, opening up the availability of more prescribers and more providers being able to deliver Medicaid services. So addressing the potential healthcare workforce shortages that I think all states are aware of. The state also purchased Zoom licenses. It's a limited number, but for some providers that currently lack telehealth capabilities, there's a link on their website if you're a person in Washington state or a state that's interested in doing something like this, where you can essentially go and apply to get one of those licenses. And then finally, as an example, Virginia's Medicaid agency issued a pretty significant provider memo that addresses a lot of topics, but one of them around SUD telehealth is allowing most behavioral health services, including those for SUD, to be delivered via telehealth, and that includes telephone per that memo. And then also they've waived the requirement that certain telehealth codes that had been used previously need to be used in this situation. It just kind of streamlines that process so that providers are able to bill using codes that they would have used previously, and cut out some of the administration there. Next slide. So we're going to switch to talking about buprenorphine, and we take buprenorphine and methadone separately because they are regulated so differently, and the policy actions around them have looked so different. At a state level, there are many actions that states can and have been taking around increasing access to buprenorphine or ensuring that access is maintained. Ensuring that those state regulations, a lot of states have regs specifically for the prescription of buprenorphine within their licensing bodies. Making sure that those policies are clear, particularly those around telemedicine and telephone right now. There's a lot of confusion there. But there are opportunities within your state regs to be waiving those things. You can, if your regs don't already do it, require co-prescribing of naloxone in an environment where we understand that overdose risk may be increasing for a lot of folks. You can require that naloxone is prescribed alongside your buprenorphine. There's also the opportunity to extend prescription length, similar to what we've seen with methadone. When you have patients who are stable, increasing those take homes up to 28 days may be a good decision. Leaving that up to clinical discretion is what most states are doing, but allowing for the extension regardless. Removing prior auth for buprenorphine. Some states have already done this for all forms of buprenorphine. Some of them have done it for the sublingual forms, but maybe not the injectable. But this is a time where folks can go ahead and just remove that prior auth for now, in the interest of getting MOUD out to folks as quickly as possible. And of course, removing any sort of cost sharing barriers that may exist, particularly for your expansion population. When we look at what that might look like from a provider perspective, there are kind of ways that you can implement those things at a clinical level. One of those is to ensure that you are seeing the maximum number of individuals possible among your waivered providers, really prescribing to the top of your ability to do so. And we know that those look different for PAs and NPs and for physicians, but being able to prescribe at the top of that is ideal right now. And you can seek a temporary increase, which if you're able to do is a good idea. Leveraging telehealth, of course, to the maximum extent possible, doing whatever you can to try to keep folks at home and try to encourage that social distancing, but of course, provide a mechanism for folks to be able to do in-person induction and maintenance if they need to, especially for populations that maybe are unstably housed. Know that some folks are still going to require an in-person visit and take all the precautions that you need and that they need as far as getting to and from the clinic. Again, extending the number of days of a buprenorphine prescription at your clinical discretion. And then considering switching the form of the drug that is being prescribed for MOUD. For folks that are on a subcutaneous buprenorphine product, if necessary, there may be clinical indications to switching that person to sublingual. If that is easier, if they're worried about that period of time where they may need to come back to the clinic for that injection. I can't think of a lot of clinical indication for moving someone from a buprenorphine product to a Vivitrol product, but there may be situations out there, and doing that carefully and in a very controlled way may be something that your patients could benefit from. Or if folks need to move from oral naltrexone to Vivitrol and do an injection in order to maintain their safety, that may be an option for you as well. And I think Jacqueline's going to talk about some of the ways that Virginia has enacted some of those policies.
Yeah, and I think it's mostly to say that Virginia did a really nice job pulling together these options, explaining them clearly, and the changes they were making, including you can do buprenorphine without an initial in-person visit. You really want to see providers co-prescribing naloxone. Select OBOTs can do longer prescriptions. The thing I would also lift up from Jodi's comments is back to that. Some of these are actually long-standing options, and many of us have kind of been pushing, would it make sense to do this not just during a pandemic, like getting rid of prior authorization for all forms of buprenorphine is something that, that medical societies recommend. It's something that could be done on an ongoing basis. Certainly essential now, but also keep an eye on it. It really may make sense on a long-term basis as well. And that ability to get rid of prior authorization is long-standing. It sits in the discretion state agencies have over Medicaid, so it's not something that's linked to the current pandemic. So, should we go to the next one, Jodi? And I think okay. Oh, I'm going to jump in on this one.
Hey,
okay.
Yep,
So
okay.
on methadone, as Jodi said, it is regulated, of course, we all know, somewhat differently. We've got some temporary easing of the methadone dispensing requirements. And unlike what I just said about prior auth, which everyone could get rid of permanently, what we're talking about now, for now, is temporary and linked to the pandemic. We haven't seen any changes in who can dispense methadone. It's still only licensed OTPs. We're still also seeing that induction must be completed during an in-person visit, and that's that issue I flagged earlier where SAMHSA is still saying that, so we've still got that in place. But maintenance can be provided through telehealth in light of COVID-19, at least for now. The take-home policies, where SAMHSA has said states can go ahead and request blanket exceptions to allow patients who are stable to take home doses of up to 28 days, less stable patients up to 14 days, all with, and I think Dr. Snyder did this really well last time, all of course subject to your clinical opinion and expertise, right? The blanket exception language is really to say that a state can ask SAMHSA that can it give its providers permission to use their clinical discretion to do this across the board in the way that they consider appropriate. So, and I really want to lift up that the state has to request this blanket exception so that your providers then really can use their clinical judgment and discretion, because this is a place that's not on autopilot. States need to kind of step in and make sure that they've asked that. And then on home delivery, there is a DEA exception in place now, allowing for more doorstep deliveries. It still is fairly heavily regulated. Authorized OTP staff member, law enforcement officer, National Guard can make a doorstep delivery in an approved lock box. Let's go to the next slide. All right, and so just in terms of those state policy levers, as they really are, to go ahead and be explicit if you want to take advantage of some of those options for your clinicians to decide to do those take-home doses. We're also seeing, and Jodi's going to walk through some examples, states that are stepping in and, for example, working with their OTPs to require staggered hours so that to the extent you do still have some people coming in for induction or some folks who really are not stable enough even for a 14-day dose, that they're not all coming at the same time, that you're at least maybe moving to alternate dosing days. And those are all, since states also oversee OTPs, you know, everybody's registered and credentialed through SAMHSA, but then there's the layer of state policy oversight. These are options too for states to work with their OTP clinics on. So encourage you to look at those. For providers, I do think it comes down to what Dr. Snyder said last time in terms of using clinical discretion to look at that 28 and 14-day supply options, trying to move to telehealth as much as possible, and using delivery for patients who can't safely leave their homes.
And just to highlight some of the action that's going on in states, SAMHSA was very quick to get guidance out to OTPs, and many states have aligned that guidance to their state policy and state guidance as well. To highlight one of the states that's doing such things, Massachusetts did start doing take-home exceptions for 14 and 28 days, but one of the other things that they did was kind of moving a little bit further so that they delineated patients that were most likely to need those longer take homes, folks who had a lab confirmed case of COVID-19, folks who had comorbidities or chronic conditions that made them more likely to be susceptible, and folks who were over the age of 60. They also are requiring lock boxes for patients in order to take those home, which again, many states are doing, but we like to see states that are going a little bit further in implementation. So we can move to the next slide. Lastly, just talking a little bit about counseling, and we'll try to do this quickly. Many states require, whether in their Medicaid programs or their buprenorphine prescribing regs, they do require counseling alongside medications for opioid use disorder. In this environment, many states are taking steps to either remove that requirement or not penalize if that requirement isn't being met in their Medicaid reimbursement. There are still opportunities for states to be encouraging the use of counseling and peer support, certainly. Doing whatever we can via telehealth at every level of care is important and helpful and good to be flexible. It is important to note that with peer support services, they may need, your peer population may need additional supports if they haven't used telehealth previously, in both the technological pieces and providing that, as well as a little bit of training. But there should be allowances made in order to promote telehealth at all levels of care. And I'm going to let Jocelyn close out with a spotlight on a couple of states.
Yeah. So we are seeing states step in and go ahead and temporarily suspend counseling requirements. Frankly, a lot of states were starting to move this direction, even in the absence of the pandemic, of allowing the medication to go out, as is now, I think, increasingly viewed as a standard best practice, even if people are not able to get connected to counseling. So West Virginia, which has relatively comprehensive counseling requirements, went ahead and just temporarily suspended that for the duration of the pandemic. I know we are running short on time and we wanted to make sure we had questions. So I'm thinking, Karen, Ken, Jodi, why don't we kind of leave it at this and take some questions for now and know that this is an ongoing conversation, and we'll have a chance to come back and talk about some of the additional issues.
Great. Jocelyn, Jodi, thank you for that amazing comprehensive work. We did want to try to get a few questions in. We've got some really terrific ones coming through, and I'm going to quickly just start to go through some of those that are at the top of the list. We have a number of people interested in any opportunities for telehealth and jail-based MAT. I will preface that we are also talking about doing a specific webinar on this topic, but let me just quickly see, Jocelyn, Jodi, any of the state policy work that you see that's included a focus on how to manage MAT in the jails?
So what I would say on this one is there's, of course, appropriately lots of conversation about this pre-pandemic, and I think a huge area of focus and an area where much more work is needed. In terms of the COVID-19 pandemic specifically, we have not yet seen a lot of work on this beyond the general, we should get people out of jails. I actually think the best, and Medicaid has some really tight restrictive limitations we might be able to waive, but I actually think in the short term, the best way to get at this may be the new $150 billion going to states to respond to the pandemic. That's very flexible funding. There's literally one line about allowable uses that it needs to be necessary to address the pandemic, and this situation seems perfect. You know, we'd have a lot more flexibility under those new dollars coming out.
Interesting. Great. Right. Thank you. Thanks. We had a number of questions about any state guidance. Jodi, maybe you could comment on this, state guidance for harm reduction providers.
Yeah, that's a good
Payment
question.
and inclusion, and their inclusion in the broader policy conversation.
Sorry, yeah, that's a good question. I have been on the hunt for guidance coming specifically from state health departments. I haven't seen that. I know there has been some informal guidance state to state that has gone to those specific comprehensive harm reduction sites. There is a good resource through the Harm Reduction Coalition that includes guidance for folks who are using drugs as well as for harm reduction sites. And I would encourage folks to look for that. It's a very comprehensive resource.
Right, thank you. Right. Our next question starts, I'm a 67-year-old peer specialist, and Hannah, perhaps you could comment on this. Should I get out there and meet with clients at the residential campus, provide rides in my car? So really, I think, referencing a risk to themselves in terms of infection.
I think that's a good question, and it's a question that every individual is going to have to answer for themselves, knowing their own health history and in partnership with their employers. But what I'll say is that as much as possible, we're advocating for physical distancing and social embrace, right? So we want you to be able to support your clients as much as possible through phone calls and texting and telehealth and things like that whenever possible. And we know that there are going to be some times where you can't do that, where the patient really needs a face-to-face interaction. So some organizations are in those cases saying, you know what, we're still going to go out there and do the work, but we're going to stand 6 feet away all the time. Or, you know what, we're going to make sure that the people who are out there doing the work are maybe our like younger, healthier employees who feel comfortable doing that work. So that's something that everybody's deciding on a case-by-case basis, but it is so important for us to still be connecting with our patients and not pulling back at this time.
Great. Thank you, Hannah. Thank you. We had a couple of questions about Medicaid, and is there opportunity for Medicaid expansion in non-expansion states under these emergency waivers? Jocelyn?
Yeah, I can jump in on that. Certainly, any state that hasn't expanded this pandemic is going to be bringing home just the significant numbers of people who are uninsured in the absence of that expansion. I would note, especially with the unemployment rising so rapidly, it's not even kind of your current uninsured population that is now getting sick. It is about to be a much larger population of people. So we are certainly seeing among the states that have not yet expanded, kind of a renewed push on it. There is also conversation in some of those states about, you know, we're not going to get to full expansion during this pandemic, or we should try, but at the same time, also look at a Medicaid 1115 waiver, which would be a better vehicle for a temporary expansion that is, you know, so we're seeing both conversations happen. I think it's a critical question and issue to keep watching, because we are going to have a lot of people without coverage who are desperately going to be needing it.
Great, thank you. Question about, just to clarify again, Jocelyn, for the states making the telehealth changes, are these written in a way that they're only allowable during the current public health emergency? Are these really tied to the emergency declaration?
That's what we're seeing, that states are typically tying it to the emergency declaration, but I do think that this entire pandemic has stirred up tremendous interest and kind of, let's go back and look at our policies. So there's nothing that precludes the state from later deciding actually this worked really well and I want to maximize my use of telehealth in general post-pandemic. But for now, we are seeing it linked to the pandemic.
To the emergency. Great, thanks. Do you, perhaps Jocelyn or Jodi, any information on whether states or insurers have made changes to allow for reimbursement for saliva tests that are FDA, instead of urine tests that are FDA permitted?
This is Jodi. I have not seen that guidance in any state.
I haven't either, but I think it's a good flag, you know, and really important to lift up.
Thanks. And is there any place to go to see if a state has requested the blanket exception allowed by the SAMHSA guidance, blanket exception on the OTP prescriptions?
So I think there's a bunch of us. I know, Jodi, you should jump in. I know NASHP is trying to track things, the American Society for Addiction Medicine, AMA. I think there's lots of folks. I know FORE is looking at this. I don't think we have that centralized list and tracking mechanism in place yet, but there's lots of interest in it. And I think, you know, one thing coming out of these kinds of conversations is the importance of getting a structured way of tracking all that, so that people know what they're dealing with.
Yeah, I would only add to that looking on your state's behavioral health website is a good place to start in the absence of that full state resource, or pick up the phone and call your SOTA, and they can probably help walk you through those things.
Thank you. I see we are right at 4 o'clock. I think if we can squeeze in one more question that had a number of thumbs up. I think it's interesting that you stated that the SAMHSA guidelines, that new patients should be seen in person, would be determinative over the DEA's suspension of that rule. Can you comment more on that? Many, including my company, have already moved forward in seeing new patients via telehealth for inductions.
Yeah, well, first, that is so good to hear. And I think we should, you know, this is one of those areas where literally like up to 10 minutes before this webinar, we were like, which way should we frame it? Which way should we put it? And I think that's one of the strengths of these conversations and webinars is a chance as a community to kind of go back and figure this out. It may make sense for us to revise that. And, you know, especially if the reality on the ground is folks are doing it. I do think, as I said at the beginning, this is a time to lean in to, in the face of ambiguity, doing what you think is right and needed. And we can kind of go back and, you know, check some of this later. I don't think there's going to be a lot of repercussions for doing our best to try to help people through this, you know, so I actually like that answer better than the answer we had in the slides. And I think we should revisit it back.
Great. Well, thank you. And it sounds like a lot of opportunity for the providers to be informing policy and vice versa, and for us to be learning from these policies at this time. I want to thank Jodi, Jocelyn, and Hannah for leading our webinar today and for an incredible, their expertise and incredible amount of information. We will continue to build on it and add to that with this team and others. And again, for all our participants, thank you so much for joining us again today. Provide us with feedback so we know what will be helpful for you next. And please do check our website for the materials from today, as well as a full document with answers to questions that we, from this discussion, as well as the additional questions that we didn't get to today. We hope to have that up in a few days for you. Thanks so much, and I hope everyone stays well. Be safe. Bye-bye.